Thank you so much. Everybody holding up okay? Excellent, because nobody eats until you guys participate in this event. So thank you so much. It's great to be back in New York. It's great to be back at this meeting in person. It's terrific to be back with old friends and hoping to meet some new ones as well. The number one rule of complications is have as many backup plans as you possibly can. So, practicing what I preach, when we downloaded this talk earlier today, none of the movies played. But I had a backup plan, and I had it on thumb drive, and we tried that, and none of the movies played. So I just ran back to the hotel and got my laptop. It seems to be working fine, but I have a backup plan. If it doesn't work, we're going to put Dr. Krishnan on the table, and we're going to do a live case. It's really an honor to be invited to do this. I do wonder a little bit what the conversation is in the room when they say, we really want to talk on complications. Who's the person to ask about complications? But I hope that they do this because of the preparation I put in and not the experience. Attending this meeting this is fantastic. I wish we'd had meetings like this when I was a fellow, but it is a lot of information in a very short amount of time. It's like drinking from a fire hose. So I'm going to try and just give you a few key pearls here to take away with you. And I'll even try and mark it sometimes like this, that this is a pearl I would walk away with. When one is early in their career and is a young pup in training, sometimes messes happen. Look, guys, shit happens, right? And it doesn't go away. That's right. And it doesn't, it doesn't go away when you stop being a young pup. This happens to the big dogs too. The hope, however, is that by the time you are done with your training, that you are able to clean up after your mess. And that is the idea. That's the concept here. So I can't exactly cover everything that you need to know about how to prepare for all complications in 10 minutes. So what I've tried to do is to pick a particular kind of complication that you should be prepared for that could happen during any intravascular intervention. That doesn't happen often, so it's worth discussing. And that when it happens in fellowship is one where you tend to get bumped to the bottom of the table, okay? The things where you don't get your hands on quite as much. And so what we're going to talk about for this are embolized devices or fractured catheters. How do we get things out of the body from the intravascular space? I'm not going to go through all of this for the sake of time and applicability, but I will use a couple of examples in terms of a stationary device and a mobile device. The objectives are to review the techniques, tips, and tricks for well-known, commonly used general retrieval devices. There are a million other things out there, but the things that are most common for a reason because they work the best. I'm not going to worry so much about the last point here. I think we're going to skip that. So, as mentioned, I'm a pediatric and adult congenital interventionalist, and so my patients are quite different than yours. We're not going to go through what a hypoplastic left heart syndrome is and all the stages. Just know that this is one of those types of patients where everything that could go wrong would go wrong. So he had an unexplained arrest after his hybrid stage 1. He had an unexplained arrest and a right IJ thrombus after stage 2. He had multiple aortic arch interventions and had the worst pseudoaneurysm I've had of any patient ever. By the way, he's about 11 or 12 years old now, and he's doing amazingly well. This was one of his early interventions here, and the point here is just that there were just tremendous numbers of aortopulmonary collaterals, which does not do well in a patient who has passive pulmonary circulation. And our objective here was to try and get rid of as many as we possibly could. Well, that's easy, right? So we start throwing coils in here, and there's the first vessel. What do you think? Pretty good? Got rid of it pretty well. Yeah, there's other stuff lighting up, but what do you guys think? Good result? I see some heads shaking. What's wrong? Nobody eats till somebody talks. Yeah, I didn't do a very good job here. This the most proximal coil didn't coil up as much. It stretched out, and here we are now blocking distal flow to the arm. So that's no good. What do? What are you going to use? A snare? Yeah, I think a snare is the right choice. A lot of people would go for this, right? A bioptome. Why? It's simple. It's intuitive. You open and you close. It's readily available, and you can get very quick control of a loose foreign body. But this is not a loose foreign body. This thing is stable, stationary. It's difficult to steer. If you do grab it, it's hard to get a good firm grab. and you have risk of injuring the surrounding tissues if you're not right on target. So we went with a snare, and really I think the gooseneck snare has been around forever for a reason. This thing is fantastic. On the pro side, it's readily available. It's very steerable. You can get super tight control of the foreign body, and you're very unlikely to harm any surrounding tissue. On the downside, it is not intuitive. The mechanics of this are tricky if you haven't played with it. It looks simple, but it's not. And I really recommend that you get an expired one or one that you've used, clean it up, and practice with it. One of my pearls from this, if you don't take anything else away, is the intuition is to grab a foreign body from the front, and sometimes that is the best or only way you can go after it. If I have a coffee cup teetering on the edge of this, I'm going to reach for it from the front, but the problem is you may knock it off when you do that, and it's the same thing when you're trying to retrieve a foreign body. Consider grabbing from the opposite side, going distal to it and dragging the snare over it rather than trying to grab it from the front, and I'll show you what I mean by this. It's working. So far, so good. So if you try and go from the front, you may push this thing further distal into the vessel. All right? However, if you get past it first and then drag more proximally, you may snag onto something and you're less likely to put it into a smaller and smaller vessel that's more and more difficult to get out. And then you tighten it, and tightening it is also not necessarily intuitive. You know, you may work for an hour to get the snare just barely onto the edge of that embolized device, and the intuition here is we've roped it, now pull it. And if you do that, the loop may slip right off the device. So what you really want to do here is almost a simultaneous advancement of the catheter and pulling away of any slack that you have. I'm trying to keep the position of that loop stable. I'll play it one more time here. So I'm advancing the catheter and pulling back slightly on the snare at the same time. Okay, so I've gotten a wire past the coil, put the snare out, snared it, problem solved, right? What's that? It's not actually. It's a good question. It's not fractured. It's a separate coil. There are two separate coils. So this thing is still intact, but we're not done. We've secured it, but what do we still have to do? You got to get it out of the body, right? And sometimes that's more difficult or challenging than just snaring it. Do you see what's going on here? We're now at the sheath, and I'm starting to pull, and the sheath is kinking, right? Now what? What do you do? Take everything out? You could. That's an option. You got to remember, at least in my patient population, we're talking about kids that are a few kilos, right? So you're going to do some damage to that blood vessel, pretty good chance, but it's an option. You can also have a surgeon come take it out. That's an option. Even in an adult patient, if this is a big device, you may not want to do that, but it's an option. What else? Go from the other side. Larger sheath, how do you exchange up without letting go? That's the tough part. So what we did was we went from the other side. And kind of the first step I like to do in that situation is make sure that we haven't caused any damage, get a better assessment of exactly where we are. And once again, I put a wire past the foreign body that I want to snare, but we now have complete control of this device, and we can manipulate it a bit. So the last time I grabbed the huge coils and I couldn't get it through a sheath. This time I wanted to set it up so that there's just a small piece at the end that we could snare, which we did. And then the moment of truth, you have to let go with one, and it pulled out just fine. At this point, we went back to work. Well, I'm sorry, we took another picture, make sure we didn't cause any clots or intubal flaps. And then we went back to work, and we've got preserved flow to the arm. So that's the stable device that's not moving. I'm going to try and go quickly through what do we do with the body in motion. So this is an atrial septal defect device closure of a colleague of mine. Got to point that out, right? This patient, unfortunately, a little girl was persistently tachycardic overnight, and on the echo the next day, that's not where you want the device to be. So we're almost completely occluding the mitral valve and the ASD, as you can see on the color Doppler, is still open. We still have a shunt. This is not a good situation, right? If this thing goes over the mitral valve and blocks it, it's the end of the game. If it goes into the LV and blocks the outflow, it's the end of the game. If it goes out to the aorta, who knows where this goes? So in this case, what are you going to choose? We run back to the lab. What are you going to choose? A snare is a great idea, and ultimately that's what's going to get it out if you're going to get it out. But it's hard. It's hard to grab that little tiny pin. So my partner did what I thought was a good idea here and chose a bioptome just to do this. Grabbed it in the left atrium, pulled it across, and now he's got it secured on the right side of the heart. Still not great if it lets go. Still not great if clots form and flow and come off, but at least it's pulmonary circulation that it goes to and not systemic circulation, right? At least you can maintain cardiac output, because even if you occlude the right ventricular outflow tract, you've got an ASD and you can get deoxygenated blood going to the left side of the heart and maintain cardiac output. So that's a good idea. He had it stabilized, and that's a key right there. A loose foreign body, particularly if it's in a vulnerable places, do whatever you can to stabilize it first. They went from the neck, and when they were holding with the bioptome from the femoral, they went from the neck and snared the pin here, and this is when I got involved in the case. Just because you've got it held onto doesn't mean you're going to actually be able to bring it all the way home. And you can see here that the problem can be that the pin is holding on to it, or it is obstructing the sheath. So another pearl here, grab objects from more than one direction. You can see here, in this case, we had it held from the bottom with the bioptome and the snare from the top. And if you do that, you may be able to orient things so that it can come all the way in. And we tried that. We got it from below and from above. And still, you can see here, it's not aligned perfectly. If you pull and it doesn't go in, what do? You pull harder. And we destroyed the sheath and could not get it out. I'm just going to cut to the chase here. We still were in a stable position, and we had time. We had it from above and we had it from below. So we got second femoral venous access here and snared from below here, and we're able to pull it through. I'm going to skip all the way through to my last bits of advice. So why not surgery with patch closure? It's absolutely a potential option. No question about it, a potentially good option. And we had the surgeons there and ready if we needed it. This is faster, right? We could get this patient to the lab and with access faster than going on bypass. It's less invasive if we could do it. And we actually pulled this out and put a larger size device and were able to close at the same time. There would be no question that it would be an appropriate first step to go to the OR. We chose this because it was, in our case, it was faster to get this patient in the lab and start. And one option could have just been go to the cath lab, grab it, just so it doesn't embolize to the systemic circulation, and then wait for surgery. Absolutely. So last take-home messages. First thing first, if it's floating around, secure it. Try and get the snare position distal to the body that you're to be retrieved. Consider grabbing objects from more than one direction and be cognizant while attempting retrieval in terms of vascular thrombosis or trauma. Assess vascular patency before, during, and after, and stock up and learn how to use the devices specific for the different problems. Now, sometimes you think you got a problem and it quickly can be over your head, and this is exactly to your point. The last thing is call your surgeon early in the game. Don't call the surgeon when you've been trying for 2 hours and you can't get whatever this is. Call them on your way to the lab. Thank you guys again. Welcome to the greatest job in the world. We look forward to being your colleagues.